I was asked to talk, if I can get my slides, please. Actually, I got a very absolute statement to talk about. Why I can do without starches. Well, you will agree that this is too absolute to give a talk, because we know from human mankind that we can do without anything and still survive. And of course we can use a number of tools, but you need to admit that if these tools are more fancy and more efficient, we get probably a little bit further. So I took the liberty to slightly adapt my talk to the question of why HES solution should not be banned from the perioperative treatment of patients. I have one disclosure to make with regard to this talk. I have received speakers fee for presentations like this by Fresenius Kabi. So, the basic question I would like to address with you is why would I need HES solution in the perioperative fluid management? Is there any reason? Well, probably there is. And time is, of course, too short to go into detail in the entire pathophysiology of fluid management. And for those of you who are interested, this is a very nice overview article by the group of Matthias Jakob in München, who gives you a very good idea about what perioperative fluid management really means and which agents that can be used for this perioperative fluid management. There is one thing we know. We know that there is, if you give crystalloids, and Azrael already pointed this out, if you give crystalloids, there is a direct relationship between the amount of fluid you give and the amount of weight gain of the patient. So the net result of giving a lot of fluid is that you get a patient who is very edematous like this, or if you look at the patient size, this is your preoperative patient and this is your postoperative patient. And this is something we do not want. Now the problem is not only that your patients look a little bit different, there is also a health problem. And this was already recognized more than 20 years ago in this article, where the authors clearly demonstrated that there is a relationship between important weight gain and postoperative morbidity and mortality. So we don't want to overfill our patients, because that's the reason why they get more complications and why their mortality might be higher. So this is a figure you probably all know. What we want to achieve with our perioperative fluid management is to keep the patient normovolemic. Hypovolemia is not good, but the other end around, hypervolemia is not good neither. So we need really to focus whether we can keep those patients here. And how are we going to do this? Well, you need to realize that perioperative fluid management is something very important where you need to have a rational approach. Don't just open up the fluid like we used to do when we were young. I remember when I was in traineeship, we looked at the monitor. We took the blood pressure. If the blood pressure was below 10, this was a spinal reflex to open the fluids and to fill the patient. This is not correct. And again, I refer to this article to give you an insight in the pathophysiological approaches to be made when we decide on perioperative fluid therapy. Which types of fluid loss do we have? Basically, you can make a division between the so-called physiological fluid loss, which is colloid-free, shift of fluid and electrolytes out of the vasculature. And we have the pathological fluid loss, which is related to a disturbance at the level of the endothelium, where you get colloid, fluids containing protein close to the plasma concentration going through the barrier. So, basically, the approach is, well, we give for this physiological fluid loss, crystalloids, where we want to replace the so-called losses, or when you are dealing with a situation of acute bleeding, you can give isooncotic colloids to prepare to replace acute blood loss. Things are a little bit more complicated when we're talking about the pathological fluid loss, but this is not really the point of my discussion. What I would like to focus on is on the perioperative blood loss and the perioperative fluid administration. So, let's go a little bit further. What do we know about volume expansion of the different solutions that are present? Well, most people accept that probably volume effect and volume efficacy of starches, the gelatins are a little bit better, but are significantly better than those of crystalloids. So if you want to give your patient volume, probably the use of starches and or gelatins is a better choice. However, things are not that simple, dear colleagues, because if you look at the type of fluids that are given and the situation wherein these fluids are given, there seem to be a number of differences. And here I will not go into detail. I just refer to this other beautiful review article of the group of München, where they clearly demonstrate and underscore the fact that the situation in which you will give your fluid, the situation in which you will give your starch or colloid will make a difference. In principle, they say there are two different modal situations that are of interest. There is the situation where you want to maintain or restore blood volume in the context of acute bleeding. And on the other hand, you can give fluids to expand blood volume. You can ask the question, why do I want to expand blood volume? But that's a possibility. Now, what are we dealing with in the perioperative period? We are dealing with a situation where we want to maintain or to restore the blood volume. So, what is the interesting point? Well, in this specific situation of restoring or maintaining the blood volume, apparently the effect of starches are very good. They have a volume effect of about 90%. On the contrary, if you give these starches, these colloids, at a certain moment in the situation of volume loading, you give them in addition to the normal volemia you want, you get huge problems. The volume effect is hardly present. And why is this? Well, we don't know it yet, but probably this is due because of that volume effect that impairs your endothelial function and gets edema of the different tissue. So this is very important. There is, depending upon the situation where you are dealing with, there is a different effect. So, starches can have a place to maintain or to restore acute blood volume loss. However, I want to use starches, and at a certain moment there is a European medical agency that centrally says no starches anymore to use in any patients. And these recommendations were based on 3 studies. Study 1, the so-called VISEP study. Study 2, the 6S study. And study 3, the CHEST study. And I'm quite sure that Professor Priebe yesterday has dissected all these studies, and you are now all convinced that these studies suffer from very important methodological issues. And what are these issues? Just to summarize, well, you see that at randomization, about 1/3 of the patients already had acute renal failure, which is a contraindication for the use of starches. Were there defined criteria for renal replacement therapy? There were not. And what is even more important, all these patients that were included were already hemodynamically stabilized before randomization. So why are you giving fluid if the patient is already stabilized, according to the sepsis guidelines, resuscitation guidelines, sorry. Okay. You have heard the talk of Professor Priebe. If you read these 2 articles, you would get all the arguments attacking or at least putting in perspective the results of these studies and putting in perspective the recommendation of the PRAC and the European Medicine Agency. Because in the end, it appears that this recommendation was only related to 1 study which showed no relevant differences and 2 studies that suffered from major methodological issues. And you all know what happens when we disregard scientific evidence. Some bad things can happen. Okay. Luckily, there was some nuancing afterwards, and now the use of hydroxy ethyl starches is considered feasible or acceptable, certainly in the situation of acute blood volume loss, when crystalloids are not considered significant. And this is important, because at least in my setting, in my perioperative setting, when a patient starts to bleed and needs volume, I can give volume in a more efficient way than with, for instance, crystalloids. And just let's go a little bit further. Concerning all these safety issues, Are we dealing with real, let's say, objective analysis of literature, or is there some other problems? This is, for instance, a systematic review on the safety of starches published by a group of researchers who don't really like starches, which is their good right. They included 56 trials and published this some 2-3 years ago. And the conclusion is that starches are not safe, that there is insufficient argument that, or no convincing evidence that the new starches are safe, so their suggestion is to ban the starches. And then, last year, there is another meta-analysis and a review, a systematic review of the safety of starches, this time in 59 trials. So these are basically the same trials than the trials used by the group of Herzog. And here, the conclusion was that starches can be used safely. So are we dealing with real science here? Or are we dealing with some people who are fighting a holy war against a molecule? I don't know. So perhaps it's time to stop the discussion about beliefs, but to start to make a rational approach to perioperative fluid treatment. And this was proposed by a group of European, let's say, key opinion leaders on the topic and published last year in Critical Care 2000, Critical Care last year. And what appears? Well, actually it appears that most of the studies addressing the use of starches in the perioperative setting do it for the wrong reason. Because actually, you should use starches, you should use colloids when you want to do an acute volume resuscitation. And you see all these studies, except one, did use the drug, did use the compound for the complete wrong reason. You need also to give this fluid, this solution, in hemodynamically unstable patients. And again, look at all the data, all the studies. There was no hemodynamic instability anymore at randomization. So if you use a drug in the wrong indication, that's what we know for many, many years now. If you use a drug in the wrong indication, you get troubles. Well, the same is true for fluids. If you use fluids in the wrong indication, you get in trouble. And this is a proposition for an algorithm for clinical management for the use of starches. If you have hypovolemia, and hypovolemia is very easily defined using the sepsis, surviving sepsis campaign. So low blood pressure, a number of variables that you can use to assess hypovolemia. Well, if there is hypovolemia, there is an indication to give this patient a volume. Is a time interval early, less than 6 hours from onset of shock, then you can use starches. Is this not the case? Then you don't have to use it, because then your patient will get into trouble and you will get into trouble together with your patient. Very important. We know that starches have the possibility to induce near kidney disturbances. So don't give it to patients. This is a contraindication. Why did all these studies give starches, in 30% of the cases, give starches to patients with already pre-existing renal failure? This is a wrong indication. This is what we would never do if we give a medication to a patient. That's what we do with fluids, apparently. And there is a maximal dose, so please keep to this maximal dose. A number of these patients in these study groups, certainly in the group of the colloids, received more starches than allowed with the maximal dose. And please, at each moment, like Azrael already discussed, at each moment, look at the fluid responsiveness of the patient. And if at a certain moment there is no fluid responsiveness anymore, don't start or don't continue to give the patient fluid. And of course you can use little boluses, but even more important, or more easy to do, is just give a leg elevation for 30 seconds and see what the cardiac outburst does. And if there is responsiveness, then you can give fluid. So, this brings me to my conclusions. The primary goal of fluid volume therapy is to correct absolute or relative volume deficit. And this in order to optimize tissue oxygen delivery. This is what we know. Please, we have too long handled fluids as being something harmless. That's not true. Fluids should be administered with the same caution as you use for any intravenous drug, on indications and taking into account the contraindications. Let's not forget that fluid resuscitation is only one component of a complex pathophysiological process, and that the fluid requirements in your critically ill patient, not only in the perioperative phase, but in the critically ill patient, will change over time. The resuscitation is not the same as the maintenance of fluid on the intensive care unit, and that specific considerations apply to different categories of patients, of course. So, should starches be banned for perioperative fluid management? There is no scientific argument at this moment to ban them, definitely, if you use them in the correct indications. And let me finish with the wise words of a guy who lived some 500 years ago and is called Bombastus von Hohenheim. You probably know him better as Paracelsus. All things are poison, and nothing is without poison. Only the dose permits something not to be poisonous. Thank you for your attention.